Good evening, everyone. So today I'd be discussing some of the rabies vaccine immunization dilemmas. For example, what would you do if someone comes late for vaccination, say after 1 month? How do you vaccinate them? Or someone who has started vaccination and subsequently you realize that it is not category 2, it is category 3. How late can you give an immunoglobulin? Or someone has started vaccination in the intramuscular plane and now it has come to you to continue the vaccination in intradermal plane. Or someone comes irregularly, say has taken the first and the second dose, and instead of coming on the seventh day is now coming to you on day 30. How do you proceed further? So some of these immunization dilemmas I would be dealing today. So first of all, we all know that rabies is one of the rare vaccine preventable diseases, which is for all practical purpose, 100% lethal. So whatever we plan regarding vaccination or prophylaxis of rabies, this is something we should always keep in mind. And what we discuss today is based on the WHO position paper 2018, as well as the national guidelines for prevention of rabies published in 2019. So we all know that the main three-prong attack to prevent rabies is local wound care, anti-rabies vaccine, and immunoglobulin. And how do we decide what should be given to which patient? We all know that is also based upon the category of bite. It's just touching or feeding of animal or animal licks on an intact skin is not considered as an exposure. All you need is to do local cleaning, nothing more. But if you have a nibbling of the uncovered skin or minor scratches or abrasions without bleeding, you need to wash the wound as well as provide immediate vaccination. Whereas single or multiple transdermal bites or scratches, contamination of mucous membrane or broken skin with saliva from animal licks, exposures due to direct contact with bats, it is considered as category 3. Remember, exposure with bats is not considered as an category 3 exposure as far as India is considered, because bat rabies has not been reported from India. It's also important for us to understand that when you are telling category 3, it is not the size of the wound. It is in fact the depth of the wound, just transdermal bite. So any bite where blood is seen becomes a category 3, however small it is. So that's very important for us to remember. And category 3 warrants that we have to give both vaccine as well as immunoglobulin. And when it comes to patients with immunosuppression, patient on steroids, patient on chemotherapy, all those patients, even a category 2 warrants rabies immunoglobulin. So first, coming to the first step, that is local care. That is, it is very important that immediately after exposure, after a bite or a scratch, we wash the area with soap and water, running water, for at least 15 minutes. What will this do? This will allow the saliva to be washed off. The viral load is coming down. And after you have washed thoroughly, clean the wound and apply either povidone iodine or alcohol. What will it do? It will again neutralize whatever more viruses which is present in your wound. Now, whatever virus you could not wash off, you could not neutralize, will be taken care of by the vaccination and immunoglobulin. Now, the important question, why? What is this role of immunoglobulin? So we need to understand that when we are normally giving a vaccine, it's usually taken up by the dendritic cells, taken to the regional lymph nodes, and in the regional lymph nodes, it initially stimulates the B lymphocytes, leading on to production of small amount of IgM antibodies. And if your vaccine, usually rabies vaccine, is also stimulated or recognized by the T lymphocyte, it will help the B lymphocyte migrate to the germinal center, cause a germinal center reaction, convert the B cells into plasma cell, and produce a large number of IgG antibodies. It also leads on to protection of certain plasma cells, which goes and hides in the bone marrow niches and produces IgG continuously. And some of the B cells get converted to memory cells also. Why did I tell all this? I told all this to imprint upon you the fact that the point is, when you give a vaccination, immediately you don't get a protection. You require at least 2 weeks time for all these things to happen and have a reasonable antibody response. It is important to understand that whatever route of vaccination you are selecting, whatever schedule of vaccination you are selecting, for all practical purpose, for the first 1 week, you definitely do not have a protective antibody. It is to cover this first 1 week that we are giving immunoglobulin. It's important for us to understand that when a dog bites, the virus is initially getting deposited in the muscles. In the muscles, what will it do? It enters the neuromuscular junction, and from the neuromuscular junction, it reaches the spinal cord and finally to the central nervous system. We need to understand that once the virus has entered the nerve, there is absolutely nothing that the immunoglobulin or the vaccine can do. It is we can neutralize the virus only before it enters the nervous system. So that is the importance, that whenever you have a transdermal bite, administration of immunoglobulin at the site of injury is of utmost importance. It is something that we should do very diligently, because once, as I already said, once it enters the nerve, there is nothing for us to do. And that is and you should know that while in the incubation period, nobody is going to spread the disease. So even if your pet has got a rabid bite from a stray dog and he's not showing any signs of rabies, initially he may not be infected. But once he starts showing some features, you should know that virus migrates from the brain downwards into your tears, into your saliva, and that is the time when the bite happens and you get infected. So it is important to understand that the effectiveness of vaccine and immunoglobulin is only before the virus enters the nerve, not after that. And so the recommended post-exposure prophylaxis in the intramuscular one, you know that it is 0, 3, 7, 14 with the fifth dose on day 28. As of now, WHO is not recommending the day 28, but DGCI continues to recommend the day 28. So we need to follow it as of now. And since it is a category 3 bite or a category 2 in an immunosuppressed, you need to give a rabies immunoglobulin also on day 0. If you're going to follow intradermal schedule, remember each dose is 0.1 ml, and that is each schedule is 2 doses. So you will be giving 2 doses on 0, 3, 7 and day 28. There is no dose for day 14. Remember, every vaccine cannot be used intradermally. Only those vaccines which are recommended or licensed by the DGCI, which contains at least 2.5 IU per dose, only those vaccines are used for the intradermal schedule. So now, if a patient has a category 3 exposure and he's coming late to you, say after 15 days or after 30 days, then they realize that someone said that dog which had bitten you or the cat which had scratched you is no more, has died. So now what do you want to do? The patient has come on day 15. Since it's already more than 10 days now, would you decide to do nothing, or would you give only the vaccine, or would you give both vaccine and immunoglobulin? So now we have to understand that rabies has an incubation period which can range normally from 1 to 3 months. A mean is around 30, 40 days, but it can come as early as 4 days or as late as more than 6 years. So it's a very variable incubation period. So if after a bite for the first 15 days you are asymptomatic, does not mean that you will not show the features of rabies subsequently. So however late a patient comes, you definitely should provide the post-exposure prophylaxis. So the patient is coming after 1 month. If it was a category 3 bite, then give both immunoglobulin and vaccine. If they are coming after 1 month, but from the history you realize it's only a category 2 bite, then you need to give only vaccine. So depending on the initial category, we need to decide what to do. Now we need to know that once you have taken a post-exposure prophylaxis, what will you do if you again have a cat scratch or a dog bite? It usually happens when you have pets at home, right? You have very frequent chance of having re-exposures. In that situation, we need to know for the first 3 months, you don't have to do anything. That means once you have a complete post-exposure prophylaxis, any re-exposure during the next 3 months, you don't have to do anything. And after 3 months, if there is a re-exposure, small or big, you need to take 2 doses of vaccine on day 0 and day 3. It can be either intramuscular or it can be intradermal. Intradermal also, you need to take only single dose intradermal is enough. So post-exposure 0 and 3. If you have previously completed a schedule. So now, what if the dog bite had happened 1 year back and you had taken a post-exposure prophylaxis 1 year back? Or what if you have taken a post-exposure prophylaxis 10 years back? So does that mean in both these situations, you're going to give only day 0 and day 3? Yes, the answer is In both these situations, you're going to give only day 0 and day 3. So there is no interval between when you have taken a pre or post exposure prophylaxis and up to what years can you take 0 3. It is you can take throughout your life, because rabies gives a very good immune response when boosted. So that is the reason they say that there is no need to re-vaccinate with the complete schedule if you have previously completed a pre or post-exposure schedule. Because if you remember our initial days of immunology classes, you would know that initial doses usually provide only a little bit of antibodies. It's once you complete the schedule, the antibody levels are high. And naturally, after some time, the plasma cells die off, so the antibody levels do come down. But even if they come down, you have enough memory cells in your body, and the moment you give a booster, within 3-4 days itself, you have a very high titer of antibody. So that is why, irrespective of when you completed pre or post exposure, when you have a re-exposure, you require only 2 doses, that is 0 and 3, and you do not require an immunoglobulin. A word of caution here. Sometimes what happens, you have a re-exposure, and it is a category 3 bite. So then someone decides, since it's a category 3, you don't want to take a risk. And so you go ahead and give an immunoglobulin. So remember, if you've given an immunoglobulin, then you cannot rely on 0 3. Then you have to complete the complete post-exposure prophylaxis, because an immunoglobulin given out of the way is definitely going to interfere with the vaccine antibody response. So just giving 2 doses there will not be effective in that situation. So now coming to, what about this intradermal and intramuscular play? Which is more efficacious? Is intramuscular superior to intradermal or vice versa? And can be switched. It's about one of the commonest situations. Sometimes you have a bite, they go to the private hospital, they have taken the intramuscular plane, and then they find it difficult to continue with the series. And then they come to the government sector, and now you're in a dilemma whether should you continue with intradermal. If you're continuing, how many doses to take and what to do. So now what does the what do you really need to know? That, as you can see here, the comparison between intradermal and intramuscular play. In fact, in this particular study, intradermal seems to be higher. There's nothing like that. Basically, you need to know that both intradermal and intramuscular schedules, as far as rabies is concerned, is equally effective. One of the reasons why it is equally effective is because, especially here, the intradermal schedule, you are giving 2 doses, 0.1 ml, 2 doses there. So that itself, and in the dermis, you have lot of antigen presenting cells, which directly through the lymphatics takes the antigen to the lymph nodes. So intradermal schedule is definitely not inferior to intramuscular schedule. Both are equipotent. And the government of India still continues to say that if the patient is on immunosuppressants, or if the patient is on chloroquine, better not to give intradermal schedule, but go for intramuscular schedule. But the latest WHO schedule does not discriminate between the two. Now, what if your pet is vaccinated? So does that mean that if you have a completely vaccinated pet, then you can rest assured and you have a bite and you don't have to take a vaccine? Yes, pet vaccinations are effective, but only if the vaccine was given at the right time, the right dose, at the right interval. Then only you can say, and the vaccine was good, of quality, then only we can say that it is going to prevent rabies in the pet. So because we are not checking for the post-exposure antibody titers in the animals, so it is always better that whether pet or wild or domestic or otherwise, whenever you have an animal exposure, bite exposure, scratch exposure, it is always preferable to take vaccine according to the category. Because as you can say, a dog is considered as immune only if the current age is more than 1 year. If the first dose of vaccine was given at 3 months of age, 2 doses were given 6 months apart, he is receiving yearly vaccination, and vaccine is of good quality. Now, so the best thing is when you are repeatedly handling an animal, say someone working in the zoo, or you have pets at home, or you have a pet shop, it would be better for you to have a pre-exposure prophylaxis. That is, if you're taking a pre-exposure prophylaxis, it is day 0, day 7, with a third dose anywhere between day 21 to day 28. In fact, the Government of India recommendation for pre-exposure prophylaxis is intradermal single dose, but WHO recommends that intradermal, it is 2 doses on 0, 7, and 28. If it is intramuscular, a single dose on 0, 7, and 28. And now we have to understand that rabies progression, usually the incubation period, as I already said, can range from 5 days to more than 2 years. Prodromal stage is for the initial 0 to 10 days. Then you have the acute neurological period followed by coma and death. And rabies can present to you in two forms: the furious rabies, which is common 80% of cases, and you also have the paralytic rabies. Usually, patients would complain of initially some pain at the site of bite, or they will say a tingling sensation. And then, if it's a hand bite, they may say that in the cervical cord, they are feeling some ache, dull ache or pain. So those kind of symptoms, when someone presents with a history of rabies bite previously, you should know, closely watch for aerophobia and hydrophobia, because they are the initial symptoms that come. So now a common question is, I have a domestic pet at home, or I have been bitten by a dog or a cat, which is in my vicinity. Do I really need to start vaccination? Is it okay that I'll observe the pet for 10 days and then decide whether to take a vaccine or not? No, the answer is absolutely not. If you have an exposure, start your vaccination and then observe the animal for 10 days. And if at the end of 10 days, the particular animal, the dog or the cat, is completely healthy and is not showing any feature of rabies, then rather than stopping the vaccination, it would be better you take the day 28 vaccination. That way, you are converting your post exposure to a pre exposure vaccination. So that would ensure that future re exposures would require only 2 doses and no immunoglobulin. So it's important you're watching the animal for 10 days. If that animal is healthy, you need to take a dose on day 28 to convert it to a pre-exposure prophylaxis. Now, why do you say observe animal for 10 days? What is so big about 10 days? The fact is that once a animal becomes infected, that is, once the rabies virus is present in the saliva of the animal, it is unlikely to live beyond 10 days. It will either definitely manifest the symptom, and most of them die within 3 to 5 days of rabies virus being documented in the saliva. There are very rare instances where it has been documented before that. That is why the 10-day period is given. Now, what to do if you have a rat bite exposure? Can rats and rabbits transmit rabies? We need to know that what you immediately you need to do is definitely wash the site, and if you require a tetanus toxoid, if you're due for it, do receive it. But usually, domestic means house mouse are unlikely to transmit rabies. The reason is not because they cannot have rabies. They can also have rabies. They can also die of rabies, but they are not considered as usual reservoirs, because it's very unlikely that a rat in your house is going to be bitten by a dog and the rat is going to survive the bite. That is the only reason why you say that it is not needed. But if, especially if you have an exposure of a rat bite, a wild rat, a rodent, a bandicoot, definitely post-exposure prophylaxis is needed. I hope that is clear, that rats do die of rabies, but in normal situations, it is not found to transmit because of the above said reason. Now, what about small animals, your rabies, your rabbits and squirrels and all? Yes, they can also have rabies. So that is also important to know. Again, like rat, they are very unusual organisms to transmit, animals to transmit rabies. That is why most of the time it is not recommended. But we should know that they can also die of rabies, because in fact, in our hospital, years back, we did have a case of rabies due to squirrel bite. Now, what about drinking rabid cow's milk? Remember, no prophylaxis is needed. Unfortunately, for this, most people take prophylaxis because there is no report of rabies being transmitted by drinking milk. Especially if it is boiled, you don't have to be scared. But that does not mean that you should be really distributing a rabid cow's milk. You should not be doing that. You should not be taking the meat also. But oral transmission of rabies has not been reported. Now, what about mongoose bite? Remember, as far as bites by a wild animal is considered, a bite or a scratch, a category 2 also warrants that you need to take immunoglobulin as well as vaccine, because the rabies real life course has been described only in dogs and cats. We do not know in other animals. So that is also one of the reasons that any kind of exposure in a forest requires anti-rabies vaccination. What about eagle inflicted injuries or your vulture inflicted injuries? Birds don't transmit rabies. In fact, dwindling vulture population is considered one of the reasons why we are finding a resurgence of rabies. What about bats? I already said bats are considered as a reservoir of rabies in many parts of the world, but thankfully in India, it is not considered as a reservoir because there has been no reports of rat rabies from India. Now, what about large class 3 bites? So can it be suture? So we have learned it should not be suture. Why is it so? That is because when you are suturing, you are again giving another portal, another site for the virus to enter the subcutaneous plane or enter the depth plane where it can enter the nerve. That is why it is said, do not suture. As far as possible, irrigate it well, then give your immunoglobulin there, infiltrate the immunoglobulin there. You can do even daily dressings. But if it is too big and you really badly want to provide a suture, then what you do is first you apply immunoglobulin, wait for, if possible, wait for a few hours, and then go and put a very loose sutures, which allows the blood to drain. So that is important why we don't recommend suturing a rabies bite. And each of these small wounds needs to be infiltrated. And if your immunoglobulin dose is not enough for that, please dilute it in normal saline and infiltrate. As I already said, local infiltration, especially in the face, is what going to save the child. The child may manifest the disease even before the vaccine starts producing the antibody. So it that your act of administration of immunoglobulin is of utmost importance. So even for a cat scratch, remember you need to, if you have such a small scratch also, it requires immunoglobulin and vaccine, because your scratches means when the blood is seen, that means it has become transdermal. And cat is an organ, is an animal which always keeps on licking its toes. So there are a lot of rabies virus if the cat is infected in the on the top of the nail also. So as I already said, we all know that the immunoglobulin is especially given to cover the first 7 days, because after 7 days, usually your vaccine would have already produced immunoglobulin. Antibodies are already being produced. Now, how long does an immunoglobulin protect? If you've given an immunoglobulin, it is mainly intended for protection in the first 1 week, even though the half-life of immunoglobulin is close to 3 to 4 weeks. Now, next question people ask is, when I'm taking care of a rabies patient, can I get rabies from a patient? It is unlikely that you can get a rabies from a patient. It has not been reported. Even though rabies virus has been isolated from urine, blood, it has been isolated from urine. Usually it is not found in the blood. It is only the antibodies that is found. So again, one thing I would say that the old practice of giving the rest of immunoglobulin at a site distant from the site of bite is no more recommended by WHO. So your onus is to infiltrate the immunoglobulin as much as possible at the site of bite. Why is it so? Because we said the virus is not something that causes viremia, goes to the blood. It is in fact entering the nerve. So even if you want to give the rest of the immunoglobulin IM, it would be preferable that you give it closer to the site of injury rather than at a site away from that. If you have an exposure in the mucous membrane, you can dilute it in normal saline and irrigate. That is especially in the eyes. You can apply immunoglobulin there also. So that is also important. The local immunoglobulins always roll locally, not really systemically at a different site. Never take immunoglobulin and vaccine in the same syringe, and never give immunoglobulin and vaccine at the same site. It should be at two different limbs. So virus is present in sperm and vaginal secretions, and all cases of human rabies has in fact occurred through organ transplant, but anyone who takes care of a rabies patient should get a post-exposure prophylaxis. Now, sometimes what happens, you have started your vaccination and then the patient comes back to you. Patient had started vaccination somewhere else. Now they has come back to you for continuation of vaccination. And then you realize that it is not category 2, it is category 3. Now, can you give a rabies immunoglobulin now? Or in other words, how long after starting a vaccination can you give an immunoglobulin? If vaccination has already been taken, immunoglobulin may be given up to 1 week. It is not recommended beyond 1 week. Remember, if you're giving an immunoglobulin beyond 1 week, then the immunoglobulin may interfere with the vaccine's response ability to produce the antibody. So don't mix up with that. If a patient comes late, you can give, even after 1 month, you can give both immunoglobulin and vaccine. But if the patient has come to you early, has taken the first dose of vaccine, and then is coming for immunoglobulin, you can give it only up to 1 week. Now, this happened recently. That is, a child had a class 2 exposure. You started the post-exposure prophylaxis with the vaccination. Class 2 does not require immunoglobulin. But unfortunately, what happened? On day 10, the child has a class 3 bite. So now what do you do? So if you have already started a vaccination schedule and it is already 7 days post your initial vaccine, then there is no need to give immunoglobulin. You can just continue with your vaccination schedule. But for some reason, if you decide to give an immunoglobulin now, remember you have to repeat the whole schedule. You cannot go haywire in between. Now, this was a 3-year-old child who had, in fact, very small bite, a 0.5 centimeter, two bite marks. It was an unprovoked bite on her shin. And the child had initially come to us on day 25 with ataxia. We thought probably vaccine induced demyelination or something like that. But within 24 hours, she worsened and she needed intubation. And subsequently, we sent both her corneal imprint as well as saliva and CSF for rabies PCR. It came as positive. So that was a confirmed case of rabies. Now, what is the reason? What is the reason of a post exposure prophylaxis? This child had received the vaccination. She had received the 0, the 3, and the 7. And the next vaccination was due. And in between, before the next vaccination was due, the child has come to you with rabies. You should know that most of the post-exposure failure cases, they present with symptoms between the day 14 and day 28. We have seen close to many cases of post-exposure prophylaxis, and most of them, as they say, they come between 2 weeks to 6 weeks. And why it has happened could be two reasons. One is, even though the bite was small, you still are able to see a scar there and there is a healed blood there. So that was a category 3 bite, which required an immunoglobulin. And since you have not given an immunoglobulin, the virus found it a way to enter the nerve. So that could be one reason why the child developed rabies. So that is important. All category 3 bites, however small it is, you need to give a rabies immunoglobulin. Another problem is when you're giving an intradermal vaccine, it is important that you are giving an intradermal vaccine. It is creating a wheal like this. If it is not creating a wheal, that means your injection has become subcutaneous. And zero point 0.1 ml subcutaneously is not going to elicit an immune response, which is going to be protective. So it's very important that when you're giving intradermal, see that a wheal has come. In case the wheel has not come, don't hesitate. At the same time, reload your syringe and near to where you have initially given, you can give one more dose, zero point 0.1 ml, which should generate a wheel. So only if a wheel is generated are you protected. So it's important to remember, rabies vaccine is effective when given intradermally or intramuscularly. It is not effective when given subcutaneously. That is why rabies vaccine is not recommended in the gluteal region, where high risk of chance of it becoming subcutaneous there. And if a vaccine is given in the gluteal region, it is considered as invalid. So here there are two possibilities why it went for a vaccination failure. But even when you do a complete, exactly like the textbook description of post-exposure prophylaxis with immunoglobulin, sometimes still you may have a post-exposure failure. The reasons could be either we have missed out on a small wound which we did not infiltrate because of the multiple wounds that you have. So if you have multiple transdermal bite, each and every site you need to infiltrate locally. It can happen because of that. Or sometimes, unfortunately, the bite would have directly happened at the nerve ending and the virus would have entered the nerve even before your antibody could neutralize it. So those are rare causes of post-exposure prophylaxis. Now coming to the immunoglobulin. We all know we have equine rabies immunoglobulin. The dose is 40 IU per kg. Human rabies immunoglobulin has double the half-life is longer. So you require only half the dose. So you require only 20 IU per kg. So even though human rabies immunoglobulin has a short half-life when compared to rabies monoclonal antibody, but half-life is longer when compared to equine rabies immunoglobulin. So, and now you have the newer moiety, that is rabies monoclonal antibodies, which is you have two brands which are available, currently available. One is given in a dose of 3.33 IU per kg, and the other one, Twinrab, which is a cocktail of two, is given at a rate of dose of 40 IU per kg. So whatever it is, all three are equally effective. And monoclonal antibody, there is no batch to batch variability. So many people feel that that is better now. Regarding equine rabies immunoglobulin, you should know that the present ones are really purified. The chance of having anaphylaxis is less. And also remember that in fact, there is no role for skin test, because even if you do a skin test, It may be negative and still you can have an anaphylaxis. And the other way around also, when you're giving a skin test, you may be in fact sensitizing the patient for a further anaphylaxis. So routinely, WHO does not recommend a skin test, but if the product leaflet says it needs to be given, it may be given, but normally, as I said, it does not predict in either way. And either way, you have to anyway give the immunoglobulin. So even if there is a reaction, you have to give a steroid as well as adrenaline, and then go ahead and give the immunoglobulin, because that is mandatory here. So now we already said both human rabies immunoglobulin and monoclonal antibodies are comparable when it comes to day 3 and day 7 binding rabies antibody titers. Now, what do you do when you have an interrupted schedule? So what happens? The child has come on day 0, day 3, then did not come on day 7, and now coming on day 30. So now what do you want to do? Do you want to restart the whole schedule, or do you want to just continue from where stop? So here there is a small difference of opinion. The 2019 guidelines do not definitely say that you have to restart, but they specifically say that 1 or 2 days delay, you don't have to restart, just continue from there. But if there is more than that delay, then you may consider giving extra doses. But WHO is very categorical regarding this. That is, if any doses are delayed, vaccination should be resumed and not restarted. In fact, that sounds more scientific, because that is what we have been already always taught. There is no need to restart any immunization schedule, however long the interval is, because longer the interval usually produces a higher antibody titers. So you just need to resume from where stopped and not exactly restart. And what about change in route? Very common, starting with IM, then coming for ID, or starting with ID and then coming for IM. You should know that there are no studies which has really looked into the efficacy of this switch. So that is why none of the agencies recommend switch. But in an exceptional situation, if it happens, if a patient started in one schedule and has now come to you for another schedule, you can continue the same schedule. That means this is what the WHO says: a change in the route of administration or in vaccine product during pre or post exposure prophylaxis is acceptable if such a change is unavoidable. So here also, you don't need to start from the beginning. You can continue from there. But I would say that when you are continuing from there, that is, you're mixing two schedules, I don't think you can skip the day 14 dose. You will need to take the day 14 dose also. So the final take-home message is rabies is 100% fatal. Appropriate post-exposure prophylaxis is highly efficacious. It is the depth that decides the class and not the size. In immunoglobulin and vaccines are effective only for neutralization of virus before it enters the nerve. So again, repeating, it is the local administration of immunoglobulin that is what important. Giving immunoglobulin a site distant from the site of injury is not of much use, because this is not a virus which goes for viremia. So even if you're giving the rest of the immunoglobulin, give it at an intramuscular site nearer to the site of the bite. Immunoglobulin are for the protection of the first 7 days. So do not give immunoglobulin once you have started the vaccination and it is more than 7 days. Newer monoclonal antibodies are as efficacious as the human rabies immunoglobulin or the equine ones. Thank you. So with that, we end today's session. For any further reading, you can refer to the book, the link I have given in the description. And also for any queries, you're welcome to ask in the comment box. Thank you.